Very important for us to spread this concept of brain death. And of course, in 1968, the Harvard Medical School published a landmark report saying the definition of irreversible coma, that is brain death. And in 1995, the American Academy of Neurologists proposed the definition of brain death. So, brain death, it is independent of cardiac functions, independent of respiratory functions, it has its own weight. And this definition of this American Academy of Neurology definition of brain death exists even now, right? So, what is brain death? So, according to the American Academy of Neurology, brain death is the irreversible loss of function of the entire brain, including the brainstem. Patient who is brain dead, is pronounced dead. An American College of Critical Care Medicine says brain death is the irreversible loss of all functions of the brain, including the brainstem, right? But then, how do we know? So the practical scenario is, before that, for example, a trauma case. Trauma is emotionally charged situation in an ICU or in any hospital, in a situation in an emergency. Patient has gone through, he may be going through this process of brain death. So, how do you diagnose brain death? Absence of responsiveness and coma. Brain death basically is a clinical diagnosis. Yeah, you will be surprised to know that brain death is a clinical diagnosis. It is not an image diagnosis. It is a clinical diagnosis which anybody, even a junior doctor can, with if not certainty, but with a well rational say that probably the patient is brain dead, which involves basically absence of responsiveness and coma, which is he is not responding to your even a deep pain, that is pain to the finger beds and sternum. Simple as that. Okay, deep pain, don't take a hammer. It is a pain to the finger bed and to the sternum. You run your knuckles on the sternum, or you pinch and he does not respond. So the first tick, you can go ahead. In absence of brainstem reflexes, pupillary reflex, you shoot a light. For example, the patient is still in the emergency in the van, and you go, he is severely damaged. You you shoot a light in his pupils. Pupils are dilated and fixed. Now you are treading that zone. Dole's eye phenomena, anybody? So pupils, you are looking at the cornea. You turn the head, and the patient eyes moves towards the direction. It does not. There is no conjugate movements towards the center. That's a positive. That means he is probably, brain is damaged. And exclusion of reversible causes, drug intoxication. He's come with a, patient is not moving. You're not sure about patient intoxication. You cannot declare it as a brain dead. Serum sodium less than 25, serum sodium above 155, serum glucose less than 40, arterial pH less than 7.3. These are all the exclusion criteria. You cannot suddenly jump and say he is brain dead. You need to correct all these things before. Take time. There is no urgency to declare him as a brain dead. You are saying he is dead. So body temperature less than 32. Do we need a EEG for a brain death? Do we need a cerebral angio? We actually don't need any of those. These things are enough to certify a brain death, and until this point, a neurologist, neurosurgeon, or an anesthetist, intensivist not belonging to the transplant team can diagnose brain death. They can certify brain death. I mean, they should not be a transplant team who is coming to remove the organs and their intensivist or an anesthetist say no, that's not valid. Okay, but say for example, intensivist and the neurologist, they don't agree on the diagnosis. PCO2 was 15. Intensivist says okay, neurologist says no, it's not. There is a misunderstand, I mean they don't agree on this brain death diagnosis, then we need imaging. Okay, so the role of the imaging comes when the two doctors who are supposed to diagnose, they are not on the same page. So, and the preferred one is EEG, and you need to show the cerebral blood flow. And how do you do it? Angiogram. Non-invasive would be transcranial Doppler. Okay, so most of the times in trauma and all, I haven't done the imaging in any of the so far I have done. So importance, I mean, why do we have to diagnose brain death? I mean, like, you know, I mean, he's dead, I mean, get on with it. No. Except the organs retrieval, the other things which can help is end of life decision making for the family. You know, they don't know. I mean, have we had these situations in our own hospital? Yes. You know, wherein the patient is pretty much going towards the brain death, and it helps the family. I mean, he is tending towards that, so they have to make some property, any issues could be there. So they need to decide among in the family. Legal issues, they need to settle the matters, judicial matters and all those things. Certainty of death, you know, and avoiding unnecessary investigations. And because some attenders might be, you know, going on and on, but then once there is a brain death, the physician, the treatment team can say we are no more treating. They cannot force us after the brain death to continue treatment. Before the treatment, yes, they can say, although there is no meaningful existence, there won't be any meaning post recovery. If you can counsel them, they can say, no, that's fine, he's going to be on a ventilator for life, go on. But once you diagnose brain death, you can say, now the treatment team or the doctors have the right to stop. They cannot force you beyond that point. And of course, for them also it cuts costs, isn't it? And what is the importance of brain dead organ management? And so now is the core topic is, I mean, I was talking about what is brain death and what causes it. Now, why should we maintain a guy who is dying? Why should we maintain a brain death patient? That is, we need to maintain those organs inside the body. I mean, you know, the brain is the one which is going haywire, but he's got two kidneys, a liver, a heart, lungs, cornea, which could go on to some other people. So almost like, you know, 1, 2, 3, 4, 5, 6, 7. So 7 people can get benefited by maintaining that person in such a volatile situation. He is an extremely volatile situation. As we go along, you will realize. And improving the quality of transplantable organs. Now, somehow extracted organs we have put in another body. Do you think that's going to be a quality transplant? No. Transplant organs not maintained well, the brain dead patients not maintained well, the chances of transplant rejections are extremely high. You know, suddenly after 6 months the transplant fails. You know, so you can avoid those situations. Reducing transplant complications, that is, you know, suddenly you have a delayed graft functioning, rejections, and improving the overall success of the transplant procedure. Transplant program is a very prestigious, very laborious program run by the hospitals, and this is the cornerstone of that transplant program. You don't maintain an organ, or the organ is coming from somewhere which was not maintained well, it's dooms, you know. It is the Cushing's response which is good for us. But what happens in one of those causes when, you know, bleeding you cannot stop, meningitis is very bad, swelling is too much, ischemia, there is a late Cushing reflex wherein intracranial pressure continues to rise and further compresses the CPP, cerebral perfusion pressure starts going down, your brain stem starts dying, medulla, vasomotor centers, pons, midbrain, they starts dying. On those vasomotor center, ischemia sets in and there is vasoplegia. So artery dilates, pressure falls, there is imbalance between sympathetic and autonomic system. And in this phase, when you put an atropine to the patient, atropine does not work. So because the parasympathetic system does not work anymore, which is a sign of severe and potentially fatal injury. This is a vicious cycle. Mass effect, raised ICP, cerebral ischemia. Initially, body tries to compensate by increasing the catecholamines, autonomic storm. This is when you see a patient suddenly, I mean, I guess our intensivist might have seen 220, 120 BP. Suddenly the, 220, 120 BP, heart rate is 160 and he goes into VF. That's the first phase of the response. And you are using basically labetalol and decrease the pressure, and then the second phase of response sets in, which is vasoplegia, and they will be using inotropes. So areas of significance. So this is the, that is the pathophysiology, the brain going down, BP raising up and down is what should be maintained. That is the maintenance of the brain dead organ patient. Now we'll see. Areas of significance around brain death is hemodynamics, fluids, electrolytes, respiratory, endocrines and all these things. Hemodynamics. As I said, there are two main phases. One is the autonomic storm, another is the severe vasoplegia. Autonomic storm, invasive monitoring, maps, we put in invasive lines, we will be measuring serum lactates to see whether body is getting perfused. Serial echocardiography, because at that pressures heart does not pump anymore. You have a stress cardiomyopathy, we want to see whether that is setting to change our inotropes. NTG, which is a vasodilator we will be using, and sometimes they will have a VT. I have cardioverted a brain dead patient and reverted, and morning we have taken for a transplant. And you have a severe vasoplegia which later sets in, which is almost, you are losing the patient. The fluid gets into the interstitial system and cause interstitial edema of the lungs. So as a result, you have to intubate him, mechanical ventilation, ARDS goes in, P-plats goes up, and all that. That's the neurogenic pulmonary edema. The mechanical trauma is also sets in, and also a dying brain secretes a lot of new cytokines which can activate the neutrophils, macrophages, which again start damaging. It's like pretty much like a severe ARDS. So you are maintaining your lungs as well. Being the respiratory targets, these are the ARDS, pretty much ARDS targets, SpO2, PaCO2, PEEP and a closed circuit, wherein an experienced, our team does this on a regular basis. Fluids and electrolytes, I mean, which special fluid does we use? There's no special fluids, it's the same, NS/RL. Electrolytes, serum sodium, I mean, serum sodiums will be trending high because your water is getting lost. You need to maintain 135, 145. The liver transplant people will be very finicky about this, suddenly they use it, because evidence says that the sodium of 155 and plus, the liver transplants don't do well. Normal values of potassium, magnesium, you will be doing them on a regular basis, checking them. Watch out for diabetes insipidus. What is diabetes insipidus? Making free urine. There is no ADH. So ADH is secreted by the brain to conserve water. Here the brain has gone for a toss. There is no hypothalamus pituitary axis is dead. So ADH is not secreted, water is not conserved in the body, right? So patients start making urine. You can see those phases, where there's an autonomic storm and then they start making urine. I mean, recently we had this lady who came with a ischemia and she's pouring 400 ml, 500 ml urine, she's going through those phases. So diabetes insipidus, watch out for a diabetes insipidus because increased urine volume. She is making about 3 to, so it's minimum 300, 400 ml of urine is going. And as the free water is lost, sodium goes up, hypernatremia. And serum osmolality, definitely you are losing free water, serum osmolality goes up and urine will be extremely dilute. So how do we counter this? Dextrose or RT free water. I mean, you are losing free water, so you replace free water, right? And how about giving an artificial, a synthetic ADH is nothing but desmopressin, isn't it? Desmopressin and vasopressin. So desmopressin IV 1 to 4 mics repeated as necessary. And if the hypotension is there, vasopressin can be your inotrope of choice. It takes care of the BP as well as conserves water. Synthetic storm, causes cardiac arrhythmias, cardiac contractility, Takotsubo, stress cardiomyopathies. It's a vicious cycle. Again goes to vasoplegia, again damaging the brain. So all that we discussed. And there is a respiratory damages as well. What happens to the endocrine system? I mean, how do we deal with the endocrine? Should we give something to the patient, a brain dead patient? We want organs at all cost, right? We want to preserve him. I mean, take it to yourself that, this is a patient, this is no more a life, so don't take it in a wrong way. No more a life, there's no life there. So basically you are doing it for those organs so that somebody else gets benefited. So thyroid hormone, what happens to the thyroid? I mean, just like in any critically ill patient, even these brain dead patients are known to be hypothyroid. Not because there is a central hypothyroidism, not because the thyroid is not secreting, but the secreted thyroid hormones peripherally are inactive. So, and the decrease in thyroid hormones leads to decreased cardiac contractility, isn't it? Hypothyroid is a cardiac contractility, is a vasoplegic state, and decreases the hemodynamic instability. It can exaggerate the BP, low BP. So shall we give thyroid hormones? There is no strong data, there is no RCT which says you give thyroid hormone it improves, but the observational study shows that, of a pretty large observational study says that the preparation of the organs, thyroid hormone given, there is a better chance of organ retrievals. So consider thyroid hormone, the consensus guidelines is consider thyroid hormones if he becomes hemodynamically unstable. So in this dose, T3 and T4 given in IV doses. Corticosteroids, is there a benefit to feed him just like in any other patient to prevent sepsis, translocation of the intestinal bacteria into the if at all the brain dead process takes time, probably for a patient somebody may just go down within no time, somebody may take 2 days for all these changes to evolve for you to declare him brain dead. So please nourish him. Temperature dysregulation, I mean temperature, yes, loss of hypothalamus is our thermoregulatory center which is gone, and there is no metabolism happening in the body, absence of muscular activity. So all this will lead to hypothermia basically. No muscular activity, no hypothalamus, no regulation, absence of an increased heat loss because of vasoplegia, isn't it? He is in a vasoplegic state, so he tends to lose the central core temperature comes down. Adverse effects of hypothermia, as you all know, first of all, I mean one of the criteria for declaring brain dead, he should be normothermic. Hypothermia you cannot even declare that he is a brain dead. He comes with a 33, you can't declare him brain dead. You need to take it above 35 and then declare brain dead. So first thing, and then you have a coagulation cascade which can go along. He can become suddenly hypothermic, he may start bleeding. So myocardial contraction, again hypothermia is again a myocardial depressor. So cardiac contractility goes down. So how do we do? Target is more than 35 degrees centigrade. Devices are covering, thermal blankets, warm fluid infusions, intravascular devices. And definitely higher target in case of a hemodynamically unstable patient requiring anemia and coagulation. Brain death is associated with pronounced systemic inflammatory response. As I said, coagulation cascade goes haywire. You have microclots everywhere. Platelets are activated, coagulation cascade is activated. So it's a prothrombotic state basically. And if in case of when you are talking about taking the kidneys, taking the liver, you don't want a renal artery to get thrombosed, which is of waste. So we need to maintain, but then there is no specific guidelines as to how we do it. So we need to be serially monitoring the coagulation and ACTs if needed. The recommendation is maintain a HB more than 7, INR less than 1.5 and platelet count more than 50,000, and reasonable to prescribe low molecular weight heparin. Your Clexane or thing still goes because it's a procoagulant state. Unless he is a bleeding patient, you can still prescribe. I mean, you have a ICH, yes, of course you cannot give a LMWH, If any other causes of brain death, yes, please continue. Sepsis, is sepsis a contraindication for taking organs? May not be, because they are not, provided antibiotics have been administered for at least 48 hours. So, meningitis, meningoencephalitis, we are giving antibiotics, he goes in for a seizure or a brain swelling and brain death. Now he's got meningitis, no, he's infected, let us not take the organs. No, not necessarily. We can still take the organs. The contraindication is he's in shock. He's in a multi-organ failure. I mean, he's got a AKI, he's dialyzing, he's got ischemic hepatitis. That situation, yes, may not be. But he's a preserved patient, hemodynamically stable, meningitis, probably we can still go ahead and take the organs.